So here we go. So these cases we're going to share here are going to be similar in a few things. The first will be that they'll all have, of course, myofunctional therapy involved. Then they'll all have frenum revision involved. And then thirdly, they'll all have expansive and or growth and development type orthopedic orthodontic techniques. So the 20 years I mentioned in the intro has been basically me only doing non-extraction growth and development techniques from the age of 3 on. And so we're always looking to go wider and forward. We are looking to develop the foundation first, then the teeth second. So the underlying philosophy would be foundation first, teeth second, and then of course inserting the different components that make up collaborative care so that we could really help a child heal and also have a beautiful smile. So it's nice to have straight teeth. Everybody wants to look good, no problem. But it's really not about the teeth. And so to have a tooth-focused approach would have a different outcome. And one of the other kind of commonalities in these cases is that they all did have a kind of beginnings with a tooth-focused approach, and we can see where they are there. And then what if we go ahead and retreat, so to speak, with foundation first and then tooth-focused second? So we're going to look at this patient, Lauren. So we meet Lauren at age 14, and she has a long history, which begins really around age 3. And so OSA, obstructive sleep apnea, she'll have that diagnosis in there, headaches, narcolepsy, anxiety, depression, ADHD, insomnia, and she is a failed CPAP user. Her OSA was mild to moderate as a kid, and so they tried CPAP, that failed. Narcolepsy is you can fall asleep anywhere at any moment. Insomnia is you can't sleep when you're at night. And then, of course, if you take a full history back to age 3, there were digestive issues as well. And digestive issues, in her case, go all the way to having endoscopies to figure out what's happening on the inside. So she's been through a lot from age 3 to 14. So we meet her at age 14. And so we'll take photos. And of course, you know, the reference earlier was about having a tooth-focused approach versus having a foundation-focused approach. So that's why the title has after and before, because this would be considered an after picture because she has had 2 years of braces to get to this point, but that's somewhere else. So when she shows up to meet us, I'm taking my before picture because we're just getting started in treating her with our foundation approach. So you can see a smile here. The front teeth are straight. But when we look here, a lot of the things that we heard from Carice and Brittany about the narrow smile line, the open or dark buccal corridors, she is front tooth prominent. And by the canine, we barely notice them. There's slivers, and we go all the way back and don't see any back teeth. So we'll know from a photograph like this that she's pretty narrow. Then the profile, of course, will start recognizing a lot of the things that Brittany and Carice presented, in that there's going to be a lot of soft tissue dysfunction. So generally, I'll be saying soft tissue dysfunction. When a nice girl, Lauren, like this gets to see Brittany and Carice, then of course they will determine where all of the muscle dysfunction is coming from and then help treat it. So she's going to end up there as well. So we can get a little closer and start to recognize that, yep, perfectly straight teeth, narrow, everybody leaning in. And of course, you know, we're looking for something more than this. This is the picture that we really like to focus on. So this happens to be one of my favorite photos in any case. We just take this photo on purpose, because when you take this picture, open up a little bit and just let your tongue relax for a moment. This is a good photograph to have, because this is exactly what we just heard a moment ago, the perspective of what's going on. You know, this is not a big tongue. This is an absolutely average sized tongue, but the jaws are undersized and the teeth are really close to the tongue. And so all of a sudden you start thinking about, where could that tongue possibly be when she closes her teeth together? And so when this nice young girl closes her teeth together, that tongue has nowhere to go but back. And the fancy words, when you're reading the research, it says posterior displacement of the tongue. Well, posterior displacement of the tongue is the wording that you find in the sleep research, because having obstruction comes from the tongue being too far back. So posterior displacement is obviously leading to the air blockage, and a good reason why she would have obstructive sleep apnea as a diagnosis as a child. So all of a sudden, we take a look at this picture, we take it for all our patients. It's not a bad idea to get into a habit of this. Then you start recognizing, well, there's an issue here, and you should first of all have a good perspective of this. This is not the right size home and the wrong size tongue. That's not a good perspective of this photograph. The proper perspective of this photograph is, this is the right size tongue in a garage that is too small. So you start thinking about how important the tongue is for all of the things it's supposed to be doing. Breathing is really at the top of the list. And when we think about breathing, so my reference for the tongue would be, it really is your body's Ferrari. So the tongue is your body's Ferrari, and a Ferrari would deserve the appropriate parking garage. This is not a parking garage for a Ferrari. This is a parking garage for like a tiny little scooter. So we need to make the garage bigger so the tongue has a place to land appropriately so we could breathe better. So this is a good photograph to start taking, get your perspective straight, and then recognize if this patient's showing up with breathing problems, you would have a good reason why here. If they show up and you take this picture, then you want to pursue the sleeping breathing pathway and maybe then ask for other things to learn about it. On the side of the tongue, very clear scalloping, and a scalloped tongue is in the list. It is a risk factor for sleep disorder breathing and or obstructive sleep apnea. Obviously, when the air is trying to get behind the tongue is going to press forward. So whenever the mouth is in a closed position, the tongue is going to be forced forward to let the air go. When the tongue is forced forward, it starts making imprints on the teeth. And that's how much the tongue is forced into the teeth, is it starts to develop the imprints of the teeth on the side. So we've got all this working for us here. Then we start taking these pictures, which was just covered very nicely. And of course, we'll start taking pictures. Okay, elevate your tongue towards the roof of your mouth to see, what does the frenum look like? How does it, perform? Where is the function? And for me, I draw the line short and we say, oh, it is time to go to orofacial myofunctional therapy. And we throw those words out. Most parents don't know what that is. And so we say, yep, they're very long words, but orofacial myofunctional therapy, we try to kind of reduce it for parents and say it's a lot of fancy words, but don't be alarmed. It really is physical therapy for the head and neck. So the tongue plus the head and neck, we're really talking about all the musculature that is involved in mastication, et cetera. So orofacial myofunctional therapy, when we start sending the patients, we talk about, it's about breathing, it's about musculature, it's about posture. There's a lot going on in here to kind of reset your child. So we recognize this frenum is a potential problem. We want to make our referral because we know already if this is how the child has grown and developed, they have soft tissue dysfunction. And then the possibility of the frenum being too tight, we're going to leave that for Carice and Brittany to make the full diagnosis and make the referral. So when we go here to our photographs, we know we've got this starting point. Then we'll take a picture like this and we'll know, okay, it's attached to the ridge. Now it's attached to the ridge. We could see the little bit of the lingual bar showing there. We know this is post-ortho. So again, we're taking a look at this patient from two perspectives. One is, these are my before photographs. We're just meeting her at age 14. We want to go obviously and treat this child. So we call these before photos, but she's 14 years old, has just finished 2 years in braces. So having had a 2-year in bracket and wire technique, her teeth are straight, but her arch is underdeveloped. So the transverse measurement that was just introduced so nicely, in between T3 and 14, this nice child measures 29 millimeters. So a moment ago, we got introduced to the cotton roll being 37 millimeters and how the 37 millimeters would be appropriate for, a teenager to have at this point as a minimum almost. We think about the 29 marker. That's a really good marker because 29 isn't really good enough for a 4-year-old. So we would want to have A and J. In the primary teeth at age 4, we're supposed to be about 30 as a minimum. So 28 and 29s, those are bad numbers when we're 4. It's not a good size of the maxilla to have 29 millimeters between 3 and 14. So now we recognize she's very narrow and then very underdeveloped in the jaws, more so than the teeth. So we're going to have these narrow arches to deal with. So now we take a look at our next photo. Let's see here. There we go. So the lingual bar was placed, 2 years in brackets and wires, straight teeth, lingual bar, but we're narrow. So we're going to have to pursue a slightly different pathway. Now, when taking the whole history, it turns out since we ask questions along the lines of sleeping and breathing, it turns out she has had her CPAP, so we want to know about what was your sleep study results. And here they are. So respiratory disturbance index, RDI, the number was 65, that's 9.3 per hour. The apnea hypopnea, the AHI, 47, that's 6.7 per hour. As a 14-year-old, it falls in the pediatric category. You only need 1 event per hour to get the apnea diagnosis, and these are high enough to push her on the borderline of mild to moderate. So she comes with a diagnosis of mild to moderate obstructive sleep apnea, characterized by elevated indices, restless sleeping, snoring. OSA could account for Lauren's daytime sleepiness, needs to be treated first before considering the possibility of narcolepsy. So she gets a CPAP. She tries the CPAP out. She does have the testing for narcolepsy, which when you go through the narcolepsy testing, I know this is a whole bunch of numbers and times, but the end result is that in the note, you could see that with the note here, Lauren had 4 chances to nap and slept in all 4. Sleep latency was 9 minutes, 7 seconds, but in 3 of the 4 naps, she entered REM sleep. And so basically the napping in 3 of the 4 and entering REM sleep, all of a sudden what happens is you meet criteria for narcolepsy. So she does meet the criteria for narcolepsy. And if she's wearing a CPAP and still has these symptoms, she could achieve a diagnosis of narcolepsy in her history. What it all leads to is that she's being seen by a pediatric pulmonologist. She's being managed in multiple different categories. We saw her kind of medical struggle list on the opening slide. But the last paragraph here kind of details where we're headed. Once again, in assessment, Lauren has at least 1 and in all likelihood 2 distinct organic sleep disturbances, accounting for her excess daytime sleepiness, occasional poor school performance, lateness, and absences. I would ask her school and teachers to be understanding until the situation gets rectified in the next number of months. Basically, all of this was to produce the pathway to help her at school because she needed more time in everything, accommodations in everything. She had difficulty being awake at school. She had difficulty getting to school on time, difficulty, even making the day at school. So the absences. So all of this results in her getting more time in school, delaying everything, more time in testing, more time for projects, et cetera, et cetera, et cetera. Because here she is at 14 years old, struggling, and year after year after year, she's falling further behind. So in falling further behind, all of a sudden what happens is falling further behind at 14, you're going to be heading into high school. So it builds a lot of anxiety in her and the parents in that if she falls behind, the entire pathway could be ruined because people start thinking about, well, you have to perform well in school, then you go to a nice college, and the whole pathway is kind of set in place, and she's not heading in that direction at all. So now we have to treat this nice young girl, and we have a foundation first and teeth second approach. So we're going to use expanders first because we need to kind of grow the bone. Let's make a bigger foundation for her. So we'll take her into fixed expanders. So she's going to have fixed expanders to go from 29 to 38. So what you're looking at here is kind of the day the fixed expander was removed. So it has a little imprint and a little, gum gingivitis showing up there where it's hard to clean around the band. But the idea is what you're looking at is 9 months progress. So 9 months later, with the fixed expanders in there, all of a sudden we have a different vault, a different palate, a broad, wide open maxilla, and we have now achieved a 9 millimeter increase. So we're up to 38 millimeters between 3 and 14. Then we could take a look at the lower arch, and it's had a fixed expander also, because if the upper is going to go 9 millimeters, the lower has to follow it. So there's a fixed lower expander, and that was resting in here and banded on the first molars. And we use that as well for the 9 months, and it develops the entire mandible out to that same measurement. So now we've got a 9 millimeter change. And when we take a look at, all of a sudden, actually on the right side, you can see the tongue kind of sitting in that space a lot easier than what we saw before where it didn't fit. But now we've got this. So we've gone from here to here, and this is just fixed expanders for 9 months. We haven't done anything to the teeth. We've only worked on the foundation. So we've got fixed expanders, 9 months, 9 millimeters change, and now her tongue has a whole lot more room. So all of a sudden, we have a different child. She's starting to heal. So at this point in time, 9 months into treatment, she now starts to sleep through the night. The symptoms start to fade, so she's improving. So her face looks different because she has a bigger maxilla and a bigger mandible. So now her face is more round and more full as opposed to more long and drawn out. And all of a sudden we have better nasal breathing happening. We have better sleeping happening. We have more tongue space. All of this is kind of falling into position. So we're heading in the right direction, but now we've got to do more for her. So you can see here the difference in just the first 9 months. We've got the bigger maxilla and the bigger mandible sitting there for you, plenty of tongue space. We're heading in the right direction. We've got the right foundation. So after having the right foundation, we've got to get ourselves moving along to coordinate the teeth. So we do the teeth second. So part 2, now, of course, when the fixed expanders are in the way, those are not very helpful for the myofunctional therapy part. So I tend to do the fixed expanders first, get the foundation opened up where we need it to be. And the day we remove them, then she's going to head over to the nice folks at CTOM, which you've been hearing from already tonight. So now we're going to get her in clear aligners because, turning 15 or now 15 years old, nobody else has braces on at 15. She doesn't want to be the only one. We'll use clear aligners to finish. So we'll take off the expanders, get these scanned because we're going to make clear aligners, but then immediately we'll refer to CT orofacial myology, where she's going to work with them for many months because we have to do what you heard was prep work. Of course, the diagnostics to determine is there a frenum to release, et cetera, and then have that done in coordination with the rest of it. And it turns out through their diagnostics, they know that the tongue and the upper lip were too tight and needed to be revised. And here we are in New York and Connecticut. So we sent her into the city to Dr. Scott Siegel, who does wonderful revisions. And of course, now this is all collaborative care to help heal this child. So when we add the aligners to the case, we don't go the other direction because the whole object was to do expansive growth and development orthopedics followed by orthodontics. So when the aligners go in, they take over at 38 millimeters. So what you're looking at here is the end of the expanders. We have 38 millimeters. When we use our aligners for the next 12 months, we're going wider. We go to 41. So we take that child again wider. So we're moving out. We're always moving away from the tongue. There aren't really good reasons to move teeth towards the tongue. Bad things happen when you move teeth towards the tongue. So we're trying to move them away. We go from 38 to 41. The lower has to go the same. So the lower is going to get a little wider. And we've just coordinated all of the teeth very nicely so we can be here. So now the picture on the left is after the fixed expanders, which gave you the foundation. The picture on the right is using the clear aligners to just kind of coordinate the teeth and have a beautiful bite again. But then the big difference becomes in the smile line, of course, you have your teeth coordinated nicely and well aligned and occluding nicely. So you go from the picture on the left, which was after expanders, to the picture on the right, which just turns out to be a class photo. So, the class picture shows up very nicely. And, you can see that she's definitely healthier. And we're going to take a look at the entirety of the before and after. So she started out at 29 millimeters as a transverse measurement. After fixed expanders, instantly into the myofunctional therapy with the Frenum revisions, and the myofunctional therapy program was probably somewhere between 6 and 9 months. Then, of course, we get the clear aligners to finish the job and get to 41. So 29 to 41. The lower will follow suit. So we're going to get our same thing all the way out. We end up with a beautiful bite, coordinated teeth that don't require anything other than the fixed expanders for the foundation, the clear aligners for the bite. And here's the before and after, the beginning where she came in and had her 29 millimeters deficiency in the maxilla and mandible, the open buccal corridors. Then, of course, the narrow and underdeveloped jaws lead to all the symptoms where she was struggling with for over a decade. Then at the end, we've got this fully developed human with the proper maxilla and mandible size who can sleep and breathe perfectly. So we go from being unhealthy to healthy. So over the course of this treatment, she fades to healthy. So it's not like a light switch. It's not instant. We don't go one day I'm bad and the next day I'm perfect. It's a slow progression. And don't forget, she's been struggling for more than a decade. When we do the full history, we learn at 3 years old, these problems began. They were struggles at 3. And from 3 to 14, that's an 11-year run of struggling in the medical kind of symptom list with really no solutions. All the treatment there was based on symptoms, and treating the symptoms is different than treating the cause. So here we are working on the underdeveloped jaws. We're talking about the malocclusion to deliver a healthy child. Now, of course, at the end, she's going to repeat a sleep study so we can prove that she's got all zeros here. So all the zeros show up here, and it turns out in the entire nighttime, she has obstructive hypopneas, only 3 events in the whole nighttime. So it's 0.4 per hour. So now she comes down in all these numbers. Most of these are all zeros, and she only has the 3 in the entire night, and she was having multiple per hour before. Then she repeats, everything, the OSA as well as the narcolepsy study. Here's the physician referral form. She's back at 16 years old and a history, anxiety, depression, ADHD, was diagnosed with moderate OSA, narcolepsy without cataplexy. She has morning headaches, daytime somnolence. She used the CPAP previously. But now here we go, the tongue and the lip tie removal, palate expanders at age 15. So now we were ordering to reevaluate for the possibility of sleep apnea and then followed by the narcolepsy evaluation. So through the testing, no significant obstructive sleep apnea. So reassurance to the parent, she does not have OSA. And then she goes back through the multiple sleep latency testing to demonstrate she doesn't have the typical finding seen with narcolepsy. So her multiple sleep latency test, the MSLT, proves now that she does not have a narcolepsy condition to deal with. So we get an email, of course. The parents will send, hey, Dr. Miraglia, I hope all's well. Attached, find the results of Lauren's recent sleep study. I included the ones from 3 years ago so you can see the difference. Very interesting how she no longer presents with apnea and narcolepsy. So it certainly is interesting how she no longer, because I don't treat apnea, I don't treat narcolepsy, I don't treat insomnia, I don't treat ADHD, I don't treat headaches, I don't treat digestive issues. I don't treat that list. What I treat is underdeveloped jaws. So in my world, the underdeveloped jaws will deliver your breathing problem, and your breathing problem is going to really trigger the sympathetic nervous system. And once you've activated the sympathetic nervous system, you have a really bad combination going on. We have poor breathing, bad oxygen, carbon dioxide, and nitric oxide activity and balance. That combined with changing the cardiovascular system, then our digestive system, all of the things that fail downstream. You've got an 11-year history of this poor girl kind of suffering through everything, but treating in the symptom column really didn't help her at all. And then, of course, you have an example of where, okay, braces could be used to straighten the teeth, but braces offer nothing when it comes to tongue space, sleeping, breathing. Braces are really a tooth-focused approach. So it achieved its goal. Braces can straighten teeth, they did. But when we took a little different approach and went after the foundation first, we end up with a perfectly healthy child. So in conclusion, so this case is being written up for a dental sleep journal right now, but today we're about 2 years post-treatment. Lauren doesn't have or is treated for any of the original diagnoses. No more ADHD, anxiety, depression, insomnia, narcolepsy, OSA, all of it's gone. She has no digestive issues. She has no headaches. She basically now sleeps with nasal breathing that is silent and invisible. She sleeps through the whole night. She wakes up in the morning. She goes to school refreshed. She is the equivalent of a straight A student, has no more extra help, no more extra time, no more tutors. And in fact, recently, she just won in New York State. She just won first place in a science research contest. So here she is doing research now. What she chose to do, which was a surprise to me, she kind of surprised us at the end. She chose to do with, I think it was the tsetse flies. It was a particular type of fly that has a sleep pattern at night. And what she did was she was shining lights on them in the middle of the night. So every so many hours, she would wake them up and pretend it's daytime, right? So they would all wake up. Then she would turn the light off. She basically disrupted their routine overnight to show that the group that doesn't get disrupted at night, those flies, they have a certain amount of activity during the day. So she could document, what does that fly do during the day? It's activities. Then when you disrupt the fly sleeping at night, it won't perform the activities during the day. So she ended up showing in a fly model that ruining the sleep of a fly changes its behavior during the day. It is now an unhealthy organism. So she ended up winning first place in New York State in a science project and then shared that with us. It was a phenomenal thing to see her do with the board and everything. It's really nice. All right, moving on to Christopher, age 9.
But I'm sorry, just gonna interrupt real quick because there's a question specific on this case that I thought would just be helpful.
Sure.
Rather than go back.
Yeah.
How were you able to get from 29 millimeters to 41 on the one child? Where did she end in the fixed expanders and how much did you gain from the aligners?
Right. So let me go back to those photos because it was in here. Okay, so I can show the pictures right here. So this is the fixed expander. The fixed expander for 9 months, we took from 29 to 38. So the fixed expander delivers 9 millimeters. So we've got 9 millimeters right here in the fixed expander, upper and lower. So now we've achieved 29 to 38. Then we get to the point where we've got to move on to our clear aligners and the myofunctional therapy and the Frenum revisions. But the clear aligners begin where the fixed expanders left off. So the left side of the screen is the end of the fixed expanders. And then we go through 12 months of aligners to get to 41. So 38 to 41 would be 3. So we went 29 to 38 in the fixed expanders, that's 9. Then we go 38 to 41 in the clear aligners, that's 3. We have 12 millimeters of change divided 9 to 3, fixed expander, clear aligner. So hopefully that's crystal clear now. I must have maybe not presented that as clear as I could have.
That's okay. And the follow-up question to that, is this typical for your kids that are above 12?
Typical, yeah, we do this all the way to 18. So yeah, in my world, we do that to 18. It wouldn't matter if she walked in at 17. We do exactly the same thing. Fixed expanders first, and then clear aligners second, because that the maxilla and the mandible with the proper technique, it's again, at the beginning, we read that disclaimer. It's not meant to be medical advice, and you're not learning how to do this tonight.
Right.
You're learning that it exists. So you don't run to the office and do 12 millimeters of expansion on 18-year-old without having a technique for that. So I do teach that technique, but not tonight. So the idea is, yeah, I will use fixed expanders from 8 all the way through 18 years old in children who come in deficient, and the goal is to get them to 40. So over my 20 years, what I recognize is that healthy kids begin at 40 millimeters between 3 and 14. I don't meet healthy children under 40, and very few kids are even anywhere near 40. So we're talking these kids come between 20 and 30 is where they are, and we need to get them to 40 and above if we want to achieve, overall health. Anybody can make some front teeth straight, but that's not really what these kids need. What they need is foundational growth and development, because it's the jaws that dictate the size of the airway and the breathing. And then when you get the size of everything right, then you get the training in the musculature. That's what the myofunctional therapy is for. and frenum releases when indicated, now you really are delivering all of the components of collaborative care to heal a child like that. So that is a full resolution of the symptoms, which is very common in our practice. We don't really end up with children that remain unhealthy as long as we do foundation first, teeth second. And it's one of the reasons why I don't do anything that is kind of tooth only type of technique. You really need to get these kids a foundation, then the teeth second.
Great. And I think we'll end probably with Christopher because we do have more questions. But if there's that patient photo, your favorite photo, is there any difference that you can see with the patient seated upright versus reclined when taking the photo of Lauren?
Oh, the tongue.
Yeah.
In the center. Yeah, we take that upright.
Thank you.
Yeah, that photograph just sitting upright. It's basically the photo is taken with the lip retractor in right after the bite. So I should show that again. It's such a nice photo. Let me bring that up. Okay.
Sure.
I know it's my favorite photo.
I
know I want to do I'm going to do a presentation where I only show this one photo and talk about it for an hour. But this is one of my favorite pictures. So you can see the lip retractors in place. And this is the preceding photo. So when we put the lip retractor in, we have them bite down. We take this picture. Once you take this picture, and these are all sitting upright, we're just taking these pictures sitting upright. We ask the patient, open up a little bit. And usually that's where we stop. We just say, would you open a little bit? And they'll open a little bit and we just start taking pictures. So I'll take a few photos like this because the tongue will move a little. Maybe if they had to swallow a little, they might move it a little bit. But this is a nice picture because you do want to see what does the tongue look like? Can you see the lateral borders? Are they scalloped or not? And how does it compare to the size of its home? And it doesn't have a good home to live in. So obviously closing this mouth, the tongue goes back. It's an obstructive sleep apnea condition. So yeah, that's a nice photograph. Everybody should start taking that. Feel free to take multiple of this because the tongue's a moving thing. It's going to move around. It'll be here, there, and everywhere. But once you start taking those photos, you start to get a sense of, does it really match? It doesn't. It doesn't. You're going to recognize it doesn't. And then you need help because no one's going to move those teeth alone to get that tongue space back. So tooth movement alone will not improve her conditions, but foundation first, teeth second can heal that child. And that's to full healing in every category.
Wonderful.
So then,
okay.
Next case, right? You want to go?
Next case. Thank you.
Christopher. Okay, so we meet this nice young boy. Where are we? There we go. So he's 9. So we meet him at 9 years old. And again, his struggles didn't begin at 9. They were earlier, but he's really struggling and this is his look. So again, similar credentials, just a little younger. So 9 years old, shows up like this. And this little guy has, struggles in every category. So waking every night. Most parents, when you start talking and asking them appropriate questions, you are going to meet parents who will describe bad sleeping habits that are going on, meaning they're waking up at night, they're tossing, they're turning, they clench and grind their teeth, or they have night sweats, or they wet the bed, or, they are doing all kinds of things that are giving, the family lots of trouble that they're struggling with. So waking up every night is definitely one that you're here, and you're going to meet people who will tell you, we don't ever remember sleeping through the night yet. It's been an hour or 2, maybe 3. And they're up every night, waking up every night. So when a parent says they're up every night, it's not an exaggeration. They're probably living that nightmare. And then, you are in the best place to help. So enuresis is the fancy word for bedwetting, night sweats, night terrors, snoring, mouth breathing, struggling in school. And then, of course, similar credentials in that the picture you're looking at is my before picture because he's showing up to meet me for day 1. We're just getting started, but he has actually just had a year and a half of phase 1 orthodontics somewhere else. So we're going to look at, again, a very similar opportunity where we're going to see the before set of photographs. But again, it was a tooth-focused approach. So this tooth-focused approach will be the judge of where he got with that versus what we're about to do. You get to see it both ways. So here he is coming in. Now, all of these troubles, none of them began yesterday. So again, if you're doing the full history with the parents, you start talking about their child, you recognize that a lot of stuff dates back to age 3. Parents will start to talk to you between 2, 3, and 4 is when the struggles began. And all of a sudden you start to get it and put it all together, what they had when and when it started. The kids come in at 9, they're suffering for 6 years already. So we're very late meeting this child at 9. So profile photograph, he doesn't have lip seal. He looks like some of the pictures that you saw in the previous presentation that were presented as far as the mouth breathing component. This is a child who is 24/7 mouth breathing. If you can't have lip seal because this is your overjet, you could see those dry lips, you can see the mentalis, you can see everything that was pointed out. So Broom, if you're thinking about Broom, you've got all of that checklist right here in this patient as well. And sure enough, we have what we would consider underdeveloped jaws. But here's a nice picture, because this picture gives us an idea of where we're starting. And this, again, is my SEP, I just took this when we met him at 9. So when we meet him at 9 and we take this picture, this is what we're really interested in, the tube in the center. So the air's got to go in the nostril. So let's follow airflow. Air goes in the nostril. It's going to go up into the nasal cavity. Then it's going to get to the nasopharynx, then the oropharynx, then the laryngopharynx, and then it's going to open up again down here. So at the level of the neck, you can see how wide the tube is. It's kind of like a garden hose. But all the way, the rest of the way, it's really tiny, like a coffee stirring straw. So who wants to breathe through that? Now, we recognize excess overjet, the lip incompetence, the mentalis is strained, but all of this malocclusion we've got, don't forget, this is an X-ray of after a year and a half of a tooth-focused phase 1 orthodontic program somewhere else. So when he gets to us and we take that picture, we right away, we know this is part of our problem here. He can't breathe. And if he can't breathe, it's a direct relationship to where are your jaws. If you're narrow in back, it occupies, the airspace room. So smaller airway comes with underdeveloped jaws, because the airspace or airway or whatever we're going to call that, it's not a structure, it's a space. And that space is built by where are your jaws. So when your jaws are wide and forward, there's a bigger tube to breathe through, which makes for better nasal breathing in a healthy child. And this child has jaws that are narrow and back. So let's take a look and see where we are. So here we are with the anterior photograph. So we could almost see in this picture how V-shaped the arch will be when we see the whole thing. And so we have this V-shaped arch with a little bit of overjet. So we have this overjet, and the lower jaw is kind of tracked really far back here. And sure enough, we have that V shape we were talking about. So this is not a proper home for his tongue. That tongue isn't going to behave well in that space. So he's going to need all of the orofacial myofunctional therapy we're talking about. And he walks in with this because he's post phase 1 treatment somewhere else with a nice tooth focused approach. But what you recognize right away is, well, where are the primary canines? And we have 4 incisors, but we're still waiting on canine premolar. So this is a subtractive technique. So because he's 9 years old, those primary canines were taken out to alleviate the crowding of the 4 incisors. So basically, this was a subtractive technique. What happened here is a year and a half in, braces, and he did have an upper expander, which an upper expander only is almost useless. So now you have this child who comes in wearing this lingual control arch to so-called fix the gains that were made for the last year and a half. But meanwhile, the gains aren't really gains, because a subtractive technique was employed. His lower canines were removed to straighten the front 4 teeth. That's not additive. That's not growth and development. This is reduction. So now we've taken out 2 teeth to have these 4 align, but now we have no room for the others. So when you do talk to the parent about this pathway, we learn from the parent that this is phase 1, but phase 2 at the same office, if he goes back, is going to be 4 by extraction, because there's no room to keep them on the lower. But the upper 2 bicuspids have to come out to close the overjet. So when we take a look back, we've got this arch shape like this. We've got overjet like this. Well, the lower bicuspids won't fit, so those will have to come out. We got to lose those 2, and we need the upper 2 to come out to get the top back. But remember this picture? So who wants to retract this child now, looking at this? He can barely breathe, but now we'll take out the 4 bicuspids and retract this all back. That's not going to help him. That might make things worse. So he had a tooth-focused approach that was retractive and subtractive in nature, and he's still struggling to breathe, sleep, etc. So we're going to go the other direction. Let's get him involved with the orofacial myofunctional therapist. He had his tonsils and adenoids taken out at age 6, and it offered him about 6 months improvement, and then it went south. So he went right back to his standard, poor breathing, poor sleeping, and credentials by removing those. And we get it because you took out the contents of a very tiny tube. So if you have a coffee straw to breathe through, and you empty the contents, let's say you fill up that straw with something and then you empty it out, that doesn't make the straw bigger. It just makes it empty. So you still have a straw. Well, the problem with the adenoids and tonsils is that most of the time when you remove them, the small airway isn't sufficient for nose breathing. So the child will mouth breathe. Tonsils and adenoids removed, small airway, mouth breathing. Guess what mouth breathing does? It irritates that tissue that should be healing, and it all grows back. So he ends up having to have his adenoids taken out again because they all grow right back in. So there's a very, very low success rate for tonsil adenoidectomy to treat OSA in kids. It's 27% initially, but it drops to 9% at 36 months because the adenoids in the tonsils grow back. It was all done at Stanford University. Dr. Christian Guilleminault showed nasal breathing is really the ultimate outcome for these kids, not removal of the contents. So because his foundation is so poor, we need wider and forward. We're going right into expanders, but we'll get an upper and a lower. So upper and a lower, we'll need some brackets in here because the subtractive technique has closed off the lower space. We're going to get some brackets involved. We're going to get some springs involved. We're going to start growing everything out. So foundation first, teeth second. We are definitely going to get involved with myofunctional therapy and frenum revisions, and then we'll go to clear aligners as a second phase. So this is what it might look like when we've got the expansion done. So now we have the maxilla and the mandible totally solved, but then we'll get our brackets and wires going and put some springs because we want to slowly grow our space back. But what you recognize in the picture is there's no overjet left. So we gave him that large expansion first, then the bracket and wire to coordinate and shape an arch, the springs to kind of grow everything into the spacing we're supposed to have for the teeth. And all of a sudden you can see here, we've removed the upper expander, but now we've got the full arch development. We have the lower in place with the springs to gain back a spot for every tooth because we do want to keep all of the teeth. It's not an extraction case because he just needed foundation first, teeth second. Then of course we could look at this, and this is just 10 months later. Now, in 10 months' time, we don't have the overjet. We've got a bigger maxilla, a bigger mandible. All of the teeth have an opportunity to come in here. And now, when we take everything out of there, we need the myofunctional therapy going. We don't use retainers or anything that is fixed because he's a 10-year-old going on 11. We need to continue to grow. So there's never anything fixed after the expanders come out because you need that tongue and lips and cheeks and breathing to work the jaw growth afterwards. So now what we want to do is get involved with the myofunctional therapy, and we'll deliver what's called a guidance appliance. So there are different guidance appliances out there, but any type of guidance appliance is removable, and their focus is really on the breathing and the musculature, not the teeth. So that's exactly what we need in the interim because we're waiting for more teeth to come in. So at this stage, it's myofunctional therapy, frenum revisions, the adenoids had to be removed again. And then of course, we'll use a guidance appliance for a couple hours a day plus overnight to make sure it maintains the breathing and the musculature supportive of the myofunctional therapy so we could keep going in the right direction. So here, this is again, just a 10-month difference. So in 10 months time, we now have the expansion achieved and the alignment achieved and everything taken away. And we're heading in the right direction. So the jaws are kind of growing. We have just started addressing the musculature with the myofunctional therapy. And the lower jaw with the upper growth will release forward. So the overjet that disappeared, it was not by elastics. There were no elastics used. So even though he might have had like an 8 or 10 millimeter overjet, the moment the upper is developed nicely and the lower is developed nicely, it turns out transverse development with releases the mandible forward. And so Dr. McNamara did wonderful research on how you do transverse development, and it actually gives you a forward movement as well. So then we get to here, we can take this picture to show, yeah, well, we're definitely traveling forward because while the overjet is reducing and we're heading forward, the tube is opening up. And this is only 10 months. So 10 months later, we have wider and forward. And now we've got that tube starting to open up for him and he starts to change. So what happens in just 10 months? Well, all of a sudden, at about 8 weeks of expansion of both jaws being wider, the tongue has enough room, he can start sleeping through the night. The bedwetting stops at 8 weeks, and then the night sweats disappear, the night terrors turn into dreams. He starts to describe dreaming. So, it's amazing how a lot of kids who are having all the nightmares, when they first start to have dreams, they will tell you, I don't ever remember having dreams. I'm having dreams now. So I dream the whole night that I'm sleeping instead of have nightmares. I used to have nightmares all the time. So then silent nose breathing is what parents would report, which is very nice. And in the beginning, when he was working with the myofunctional therapist, he was struggling so much at school. As a 9-year-old, he couldn't say the alphabet without making mistakes. Part of the work at the myofunctional therapy office is to record the child speaking and eating and drinking and doing things so they learn where are all the muscle patterns at the beginning and then working them through accordingly. Well, it turns out, given multiple attempts to just say the alphabet, he would make 2 mistakes as his best attempt and 6 at his worst, really struggling academically. Of course, if you don't breathe well, you have cognitive deficiencies. That's documented very well in the research. Children who mouth breathe alone have lower IQs than children who nose breathe at night. You don't have to have OSA to have cognitive impairment. So the research is very clear. Dr. Karen Bonnick did all this for us. Mouth breathing alone, mouth breathing, snoring, or OSA, they're all bad, but mouth breathing is enough to reduce the cognitive abilities of a child versus nose breathing. So we get through 10 months and now he can read Harry Potter out loud, and him and his mom do that as a nighttime routine at this point. He reads the Harry Potter books to her and they go through the whole thing. Now we're going to get rid of our expanders, move into guides, get some myofunctional therapy going. 15 months. So we're just progressing through the case. Now we've got this wide open maxilla. The teeth are starting to shape nicely. And now in the lower, we have what would be considered mild crowding. So we have mild crowding in the lower, a tongue that has its chamber, and we haven't even gotten to the clear aligners yet. This is just fixed expanders first, some brackets and wires to regain the space that was lost by the subtraction technique. And then we're here. So now in about 15 months' time, you have a different kid on your hands. All of a sudden, this child is nose breathing, sleeping through the night. And now you've got your permanent teeth coming in. And of course, we're going to get to clear aligners. So you could recognize a couple of attachments, but we'll use clear aligners because he has a class 1 mild crowded, slight issue with the teeth. We'll just do tooth coordination now. So foundation first, teeth second, delivers beautiful alignment. Class 1 connected. If you have to see canine to molar class 1, it's right here for you to see, but it's not really about where the teeth are. It's about where the foundation is. That's the priority. Then you get your teeth second. That's how you heal a child. So the child goes through, I think it was about 8 months of clear aligners. So 8 months of clear aligners, you get a school picture during the aligner. So all of a sudden we've got the broad smile. He's got a hairstyle going, the kid's waking up. So he becomes the equivalent of an A student, no more struggles. He rejoins a basketball team that he couldn't participate on very well because of his behavior. He becomes a drummer in the school band. He does switch over to soccer. He begins playing soccer, goes all the way through varsity soccer. And now we get to maybe we might be here, finishing up our clear aligners. And as he's finishing his clear aligners, all of a sudden you've got the hairstyle and, wow, you're looking good. But we knew you were here because the Axe cologne came in the office about 20 feet before you did. So we had to make advice about maybe don't use the entire bottle of the Axe cologne. You can use a little less than that and still be okay. Here he is in 2021. This is just last year because he's fully grown. He has his wisdom teeth in place. So here he is in 2021. We're just checking him. He's probably about 18 years old here. And at 18 years old, he has, you can see in the back there, I know my top mirror wasn't as clear as it should be, but here come 4 wisdom teeth erupting with comfort, and they will erupt right into function. So his wisdom teeth erupt with total comfort and into function. And now he has 32 teeth as a full complement, but meanwhile, he has absolutely no symptoms. He's a class 1 bite everywhere, which is beautiful. So here he is, of course, at age 18, you're too cool for school. And of course, you got a hairstyle going and you're the varsity soccer, player, and you're, doing wonderful things in school with your grades and your sports, and you're going to get into a great college and have a wonderful future, all because you had growth and development first. The foundation first, the teeth second, delivers a healthy child. So he has absolutely no symptoms in any direction whatsoever. He closes his mouth when he goes to sleep and he breathes through his nose.